Hello guys, welcome to this session and today we are going to discuss rheumatology with starting off with rheumatology and the first topic we'll discuss is Sjogren syndrome, right? So Sjogren syndrome basically we'll try to cover the lines of Harrison, so don't worry, Harrison is covered. Okay, you know about endocrinopathies, right? So Sjogren syndrome is not particularly an endocrinopathy, it is an exocrinopathy. Only one endocrine gland is involved, that is thyroid, right? We'll talk about it. But it is a exocrinopathy. So Harrison writes that it is a prototype. Whenever we will study autoimmune exocrinopathy, we'll study Sjogren's, right? So it is an autoimmune disorder. Okay, we'll see in the pathogenesis what is autoimmune and exocrinopathy. Exocrine glands are involved like salivary glands. The classical manifestation, I'm sure you must be have read Sjogren about introduction brief about Sjogren in pathology. That is your dry eyes, dry mouth, all of this, right? So dry eyes and dry mouth, which you commonly read as a kid, right? So this is a dry tongue or dry mouth, whatever you can tell. Okay. So what it happens, how it happens, we'll try to discuss today. So starting off Sjogren per se, let's start. Sjogren syndrome can be broadly divided into primary Sjogren and secondary Sjogren, right? So primary and secondary. Any disorder, primary disorder, you know that there is no association. Sjogren syndrome, primary Sjogren syndrome, there is no association, right? There is no association with any systemic disorder. But secondary Sjogren is associated. Here there is no association that I'm not writing. The most common secondary association of Sjogren syndrome is basically rheumatoid arthritis, RA. After rheumatoid arthritis, it can be associated. The second most common is SLE. We'll study SLE in detail. I have made a SLE video for pathology, but we'll study SLE in medicine, which is a bit more comprehensive and more detailed, you can say. Let's focus on Sjogren's first. RA. Rheumatoid arthritis is the most common association, right? So this is the most common. Okay, most common cause of secondary Sjogren syndrome. Now, Sjogren syndrome can be a glandular pathology or can be extraglandular pathology. This glandular pathology is 50% cases. Extraglandular is 50% cases. The thing that concerns us is basically extraglandular pathology. Extraglandular pathology, some 15% of cases have a severe manifestations. Severe manifestations like in all organs. In all organs they manifest. In CNS, in liver, in thyroid, in bile duct. Okay, many manifestations are there, right? We'll discuss about manifestations, but first secondary Sjogren's, and another classification I told you is a glandular Sjogren, and 50% cases, and an extraglandular Sjogren, that is again 50%, rest 50% of cases. Okay. And this extraglandular Sjogren is, you can say, significant for us because it is a multi-system involvement, and 15% can get into life-threatening conditions, right? So 15% life-threatening, 15% is life-threatening. Okay, this is done. Okay. Sjogren syndrome, how it manifests, how it occurs, what is the pathology, what is the pathogenesis, what is the etiopathogenesis of Sjogren syndrome? Clinical hallmark, the clinical picture of Sjogren syndrome is a person who complains of sicca symptoms. What are sicca symptoms? Sicca symptoms means that there is a dryness. Okay, you can consider a desert of secretions, dry mouth, dry eye, dry throat, dry vagina, everything dry. Okay, sicca symptoms. And it is a exocrinopathy. It is a exocrinopathy, and it is a autoimmune exocrinopathy. Okay, it is a autoimmune exocrinopathy. Only one endocrine gland is involved, that is thyroid. Thyroid is the only endocrine gland involved. Thyroid is the only endocrine gland involved. Otherwise, it is a exclusive exogenopathy. Okay. These things are clear. These things are clear. Now, extrahepatic manifestations are common here. Okay. Sjogren syndrome in many cases is associated with HCV virus, that is hepatitis C virus. And due to this association with hepatitis C, it can have extrahepatic manifestations, right, in Sjogren. But otherwise, it is a exochronopathy. It is a exochronopathy. Every autoimmune disorder, I can say most of the autoimmune disorder which you read is basically having a genetic and an environmental role. Okay, the pathogenesis or the etiopathogenesis starts off with genetic and environmental factors. Every autoimmune disorder has a triad like this: genetic factors, environmental factors, immunological factors. Genetic, environmental, immunological. Okay, GEI. So these three factors can characterize the autoimmune disorder. So Sjogren syndrome per se, it the whole story starts with genetic and environmental factors. So we have genetic factors in one hand, we have environmental factors in one another hand. We have genetic factors, we have environmental factors in another hand. Right. These factors contribute to autoantibody production. This contribute to autoantibody production. Autoantibody is produced, right? It is a autoimmune disorder. It is an autoimmune disorder. This autoantibody will attack the cells and activate the epithelium. Will activate the ductal epithelium. It will activate the ductal epithelium. When it activates the ductal epithelium, it will produce what is called as genetic factors. For example, I'm giving one example. See from the Harrison's what I has to tell. Genetic factors basically it is DR3. Okay, basically it is DR3 which is associated. DRQ. Okay, DR. Look at this. HLA-DR. Okay, let us make it thin. What are the genetic factors? From Harrison's it is written. In Harrison's it is written HLA-DR, HLA-DQ. Okay, HLA-DR, HLA-DQ, STAT4, and IRF polymorphisms. These four are given in the Harrison's, straight from the Harrison's. HLA-DR, HLA-DQ, STAT4, IRF polymorphism are the genetic factors. Okay, you just remember HLA-DR and HLA-DQ. Environmental triggers. What are the environmental triggers? Basically, viral infections. In Harrison's, it is written that environmental triggers are generally viral infections. Viral infection like Epstein-Barr virus, CMV, HTLV. These are minor, but the most important most important virus which I want to tell you is hepatitis C virus. Hepatitis C virus is associated with this Sjogren most commonly, right? So if the person presenting with Sjogren is treated in that line, but you have to think in place of Sjogren also. You have to think in lines of Sjogren also. If a hepatitis C patient presents to you with jaundice and all the features, right? Okay, genetic is done. I told you every autoimmune disorder has genetic, environmental, and immunological. So we have some immunological dysregulations. Genetic is done, environmental is done. Immune dysregulation. What are the immunological factors that are contributing to the development of Sjogren? So I told you that autoantibodies are formed, that is autoreactive autoreactive T and B cells infiltrate the exocrine glands. Okay, basically the inflammation is mediated by T cells. It is a T cell mediated. It is a T cell mediated inflammation where Th1 cells play a good part. It is a combination basically, but T cell more than B cell. These are autoreactive, and when they become autoreactive, they start destroying the glands. They infiltrate the glands and start destroy this. Okay, and interleukins, interferon alpha, interleukin 12, BAFF. Okay, these are continuing the inflammation, that is perpetuating the inflammation, right? And the salivary gland enlargement is due to interleukin 8. sorry, interleukin 18. This can cause salivary gland enlargement. Salivary gland enlargement. Okay, salivary gland enlargement. Basically, interleukin 18 positive macrophages are responsible for the salivary gland enlargement. Okay, autoantibodies are formed, and autoantibodies, here it is not written, you can write it. Some autoantibodies are formed in this condition. Autoantibodies. Some autoantibodies are formed in this condition. And autoantibodies anti-M3, that is anti-muscarinic. Okay, anti-muscarinic antibodies are formed. Anti-M3. This is formed. The second one is anti-alpha fodrin. Anti-alpha fodrin. Anti-M3 and anti-alpha fodrin are the autoantibodies which are formed in Sjogren's. Anti-Rho and anti-La. Okay, anti-Rho and anti-La antibodies are positive in this case. Anti-Rho and anti-La are the antibodies which we previously thought that you must be have a expression that these are used for diagnosis. No, anti-Rho and anti-La, if they are present, it has a only minimal 5% around chances of transmitting Sjogren's. But anti-Rho and anti-La, if they are positive, it has a risk. The Sjogren has a risk of having a serious manifestations. Sjogren has a risk of manifesting seriously if they are positive. But anti-Rho and anti-La are not diagnostic. Okay, they are prognostic, you can say. So glandular destruction and systemic autoimmunity is there. Okay, glandular destruction and systemic autoimmunity can be seen. Okay, so if you look at the histopathology, if you look at the histopathology section, this is the pathogenesis we discussed. Histopathology, HPE, HPE. In histopathology, you will get two findings. One is the you can say benign lymphoepithelial regions. Okay, benign lymphoepithelial lesions which are seen in major salivary glands, and you can say lymphocytic sialinitis in minor salivary glands. Okay, so these are benign lesions. Just pay attention. These are benign lesions, and these are lymphoepithelial lesions. Lymphoepithelial lesions in major salivary gland and lymphocytic sialidinitis in minor salivary gland. Clear? These all are things. These all things you know. Okay, in major salivary glands and in minor salivary glands. Now we move to the clinical features per se. Right. Saw right. We have a glandular Sjogren's and a extraglandular Sjogren's. First, let's discuss about the glandular Sjogren's. So first feature which you commonly say is dry eyes. Okay, dry eyes. Look at this. Characterized by dry mouth, that is xerostomia, and keratoconjunctivitis sicca, that is dry eyes. Keratoconjunctivitis sicca, that is dry eyes. This dry eyes is very, very non-specific. Okay, it is associated with, let us write here. I have a space here. These are the lines of Harrison which I have brought so that I don't leave anything in discussion. So dry eyes, it is the most complete video of Sjogren's, I guess, you can get, which has which have all the things that they're from Harrison's, right? So dry eyes are non-specific finding. First thing, non-specific. It is a non-specific finding. Okay, it is a non-specific finding. What are the findings? We have a irritation, grittiness. Okay, you can say dryness or fatigue, eye fatigue, right? Irritation, grittiness. I think irritation and grittiness can be seen. Okay, irritation and grittiness can be seen, and you can say that it is associated with meibomian gland dysfunction also. So it is a aqueous plus lipid defect. Okay, aqueous plus lipid defect. And this eye manifestations are called as keratoconjunctivitis sicca. Sicca means dryness, right? So how can you diagnose this? So we have something called, for diagnosis, we have something called Skirmer test. There's something called as the Skirmer test. Skirmer test, if it is less than 5 mm after 5 minutes, less than 5 mm after 5 minutes, okay, you can call this as a dry eye. Okay, it is non-specific test, not that specific. Skirmer test, and we have a tear breakup, tear film break time. We have a second test is called tear film break time. Okay, tear film breakup time or tear film break time. If it is less than 10 seconds, then it is a dry eye. Less than 10 seconds, it is a dry eye. Okay, time is less than 10 seconds, it is a dry eye. Or you can do staining also. You can do staining also. Ocular stains are there. Staining. You can do staining also for diagnosis. Okay. And the two stains which I want everyone to remember, once the lissamine green dye. Lissamine green. I have written this in fluorescent letters. Okay, lissamine green dye, and another one is the fluorescent dye. Fluorescent. Just check the spelling. Fluorescent. F-U-L-O-R-E-S. Yes, you can leave it. No problem. I don't need to check spellings. Okay, lissamine green and fluorescent. Right. So this is about the dry eyes. This is about the dry eyes. The second manifestation of Sjogren syndrome is dry mouth. Okay. Patient's mouth has a decreased saliva secretion, due to which the patient is not feeling that is feeling very difficult to swallow food, right? Difficulty in swallow. Patient is having a difficulty in swallowing food. Okay, difficulty in swallowing, and he is finding difficulty in chewing. He is having dental caries. So many times what happens is that this Sjogren syndrome gets diagnosed in the dentist. Okay. Not coming to physicians, because these rheumatological conditions don't have a particular system you can pinpoint to, that they are causing from this system, they are going from this system to that system. It is immunology. Immunology is always systemic. Okay, whenever you are discussing a immunological condition, it is always systemic. It is not like that this condition can be localized to that part of body, or localized to that organ, or localized to that region or dermatome, anything. You can't localize it. It is a systemic condition, right? So that is the thing. Dry mouth, dental caries. You can get candidiasis, oral candidiasis, oral thrush. Okay, all the time things like that. Patient says just okay. So patient says that he has a metallic taste, right? He has a metallic taste, or you can write altered taste. Altered taste. Okay, altered taste, right? So that was a thing. Okay, patient also can present with the bilateral parotid swelling, which is symmetrical. Patient can present with bilateral parotid swelling, which is just symmetrical. If it is a unilateral swelling and asymmetrical with infiltrative margins, very, very dangerous. It is a, if it is a asymmetric swelling, which is, this is painless, okay, symmetrical and painless. If the patient presents not like this, but with asymmetrical, painful swelling, painful, palpable swelling, suggestive of B cell lymphoma, very, very dangerous. It's a very bad prognosis. Okay. So if it is a painless swelling, then Sjogren syndrome, no need to worry. Artificial saliva supplements are there. Sevimilin drug is there, right? We have treatments, but B cell lymphoma, not that, thing. And it is basically a marginal zone lymphoma. Okay, marginal zone B cell lymphoma. It is most commonly a marginal zone. This is a marginal zone lymphoma. It's an extranodal marginal zone lymphoma. Okay, and if it is an extranodal marginal zone lymphoma, then you know from your hematology knowledge that whenever there is an extranodal marginal zone lymphoma, right, it will present with decreased complements. The C3, C4 are decreased. Okay, decreased complements. Decreased complements, they always present with decreased complements and cryoglobulinemia. And cryoglobulinemia. Okay. So these two things will take your diagnosis towards, you can say, marginal zone lymphoma if you do the lab diagnosis, right? These are the things. Okay. How to suspect extraglandular Sjogren? Okay, let's look at this. Profound lymphocytic infiltration of exocrine glands. I told you it is a exocrinopathy. Some opening statements, some statements which you can say important. Male is to female ratio is 10 or 20 is to 1. Is 10 to 20 is to 1. Okay. Usually middle-aged females. Okay. 40 to 60, or you can say 30 to 40, whatever you can say, middle-aged. Okay. Middle-aged women. Prevalence is 1%, which is, you can say, significant in general population. 20% may express Zika symptoms. Okay, 20% with other autoimmune disorders, SLE, scleroderma. Zika symptoms are dry eyes, dry mouth, or all the things are dry, mucous membranes are dry. They express Zika symptoms or Zika features associated with increased risk of lymphoid malignancy, that is B cell lymphomas. B cell lymphomas. Okay, so I'm sure you must be understanding all the statements now, right? Okay, Zika symptoms, I told you: dry eyes, dry mouth, other glandular features. So dry eyes, we get gritty sensation, photophobia, conjunctival injection, and corneal ulceration, corneal ulcers due to dry eyes, right? Dry mouth is difficulty in swallowing. I told you there is difficulty in swallowing, increased thirst because the patient is not able to take his saliva also, right? Increased thirst, recurrent dental caries. If a person is coming up with recurrent dental caries and having a dryness, then you can think in lines of Sjogren, right? Oral candidiasis or oral thrush. And I told you that we have a parotid enlargement, and this parotid enlargement, I told you, is a bilateral one and a symmetrical one and a painless one. Okay, bilateral, symmetrical, and painless. And other dries are the dryness of nose, dryness of skin, vagina. So there is a dyspareunia. Dyspareunia is painful sexual intercourse. Okay, due to this dryness, the lubricating glands are not that secreting very, you can say, much. Okay, these things are there. Then another thing is that how to suspect extraglandular Sjogren. You saw glandular Sjogren. How to suspect extraglandular Sjogren? How to suspect extraglandular Sjogren? Whenever you have low complements, low C3, C4, we have low complements. We have anti-rho and La, anti-rho La. This anti-rho is called SSA. This anti-La is called SSB. Okay, anti-rho and La. Then rheumatoid factor positive, RF positive, anti-rho La antibodies. Rheumatoid factor positive and cryoglobulinemia. Cryoglobulinemia. These all factors points towards the extraglandular type of Sjogren. Okay, and anti-rolla, remember, is not that specific to Sjogren syndrome. It can be positive. If it is positive, then the person has about 4 to 5% chances of developing disease after few years, right? So you can say its positivity isn't implying Sjogren's, but its positivity in a Sjogren's, in an already diagnosed case of Sjogren's, is no, you can say, implicating extraglandular severe form. Okay, so anti-rolla, if a Sjogren patient comes to you, is diagnosed with Sjogren's particularly, right? He's already diagnosed with Sjogren's, but he comes to you for follow-up, and you saw that there is anti-rolla positivity. If it is an anti-rolla positivity, then you can suspect that the person is a risky patient. Okay, he can have extraglandular manifestations in 15% of cases. Okay, this is clear. This is clear. Okay, so it is implicating this anti-rolla positivity is implicating a which prognosis, poor or good? Of course, poor prognosis, because extraglandular manifestations in 15% of cases can lead to severe form, right? So he has a increased risk of malignancies also. Okay, so now we'll go to the manifestations. In manifestation, I told you all the Sika symptoms, you know. Okay, but patient comes to you, some Sika symptoms are there. Okay, the most common manifestation, if they ask you, it is fatigue always. It is a very, 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 very non-specific one. Fatigue. Person comes and tells, I am having fatigue. Okay, how can you just tell an Sjogren's number of causes, right? Hundreds of causes are there for fatigue. The second most common, the first most common is the most common feature, that is fatigue. The second most common is arthralgia. The person is having arthralgia, joint pain, arthralgia or arthritis. Okay, here in Sjogren syndrome, we have a non-erosive type of arthritis, which is called as Jacquard arthritis, Jacquard arthritis. Okay, so just a minute. This is the spelling. Jacquard arthritis. Okay, so Jacquard arthritis is there, then fatigue is there, arthralgia is there, all this. Okay, in Jacquard arthritis is particularly non-erosive type of arthritis. Okay, so no need to worry. Just a minute, let me adjust the camera a bit. Okay, Jacquard arthritis. This is done. Now we'll move to some extra glandular manifestations of Sjogren syndrome. Look at this. I told you musculoskeletal non-erosive arthritis is called as Jacquard. Jacquard arthritis, arthralgia and myalgia. Okay. Skin manifestations. In Sjogren syndrome, you get Raynaud phenomena. Raynaud phenomena is basically peripheral vascular disorder, right? It is producing a critical type of limb ischemia. It is producing critical, just a minute, critical limb ischemia. It is causing a Critical limb ischemia. In one third of patients, it is causing a critical type of limb ischemia. It is producing vasculitis. It is producing vasculitic rashes. It is producing vasculitis, and the most common type of vasculitis which is there in the Sjogren syndrome is small vessel vasculitis. It is most common in small vessel vasculitis. This is the most common one. It is a small vessel vasculitis. And the hallmark lesion of small vessel vasculitis is a palpable purpura. Palpable, palpable purpura. Palpable purpura. And this Sjogren syndrome can have medium vessel vasculitis, and this medium vessel vasculitis is characterized with ulcer and we can say gangrenes. And this medium vessel vasculitis is a severe form. Okay, it is implicating a severe form of Sjogren's because it is associated with other renal manifestations like MPGN or neuropathies, right? So we can have a occasional medium vessel also, or medium vessel. And I told you this medium vessel vasculitis is a severe one, and it is associated with other things. And this medium vessel vasculitis, it is associated with ulcers and gangrene. It's characterized by ulcers and gangrene. Ulcers and gangrene. Ulcers and gangrene. Okay, this part is clear. Now let's come to lungs. It is causing interstitial lung disease. It is causing interstitial lung disease. In the lung disease, interstitial lung disease, the most common manifestations is NSIP. The most common manifestation in the lung, here it is the lung. The most common manifestation is NSIP. NSIP, what do you mean by NSIP? Non-specific interstitial pneumonia. It is associated with a non-specific type of interstitial pneumonia. Okay, and it can be associated. It's if you ask the most characteristic one, most characteristic. The most characteristic lung manifestation, if you ask me, most characteristic lung manifestation is LIP, not lip. Is it lip? No. It is lymphocytic interstitial pneumonia. Okay. Most common is non-specific interstitial pneumonia, and the most characteristic lesion is the lip. That is the lymphocytic interstitial pneumonia, which can be associated with this Sjogren syndrome. Okay. It can be associated with pulmonary hypertension, which you commonly write PHTN. It can have association with pulmonary hypertension or PHTN. Okay. Okay. Uh, it is not there. Hepatobiliary is there. Okay, we'll discuss in that. Kidneys. It is associated with interstitial nephritis. Interstitial nephritis. Okay. It is associated with interstitial nephritis, tubulo-interstitial kidney diseases. The tubulo-interstitial kidney diseases, and the most common association which we commonly see is a renal tubular acidosis, that is RTA. And RT, which type of renal tubular acidosis? Distal RTA. It is most commonly associated with distal RTA. Okay, distal RTA, type 1 RTA. Distal arterial type 1 RTA. Okay. Distal arterial type 1 RTA. Okay. Then nervous system. What are the manifestations in the nervous system? So don't get nervous. It will be easy. Peripheral neuropathies. I told you that whenever the Sjogren syndrome, it is associated with peripheral neuropathies, right? Peripheral neuropathies. It can be associated with ganglionopathies. Ganglionopathies. Peripheral neuropathies or ganglionopathy, that is dorsal root ganglion is affected, DRG affected. And whenever DRG is affected, the patient will present with truncal ataxia. Truncal ataxia. Right? This is of CNS manifestation. Hey, this is the brain idea. Okay, this is the thing. This is the thing. Myelopathies may be associated. Cognitive dysfunctions. Okay, the cognition, the memory may be affected. Okay, all of this. GI and hepatobiliary, I told you dysphagia. Dysphagia is common. But the most common thing is that autoimmune hepatitis, it has an association with autoimmune hepatitis. It has an association with hepatitis C virus, HCV, HCV, HCV virus. And a gallbladder condition, which is very, very, very commonly asked, it is associated with PBC. What is PBC? Primary biliary cholangitis. That is PBC. And we have a PSC also, primary sclerosing cholangitis. Okay, we'll see that in other disorders, right? Primary biliary cholangitis is basically a intrahepatic bile duct. Okay, there's a destruction of that intrahepatic bile duct. Okay, it is also autoimmune condition. That is the thing. And the second thing is that hematology is the last thing I can say. And the hematological conditions. What are the hematological conditions that may be involved? So you can have cytopenia. You can have hypergammaglobulinemia. You can have an increased risk of lymphoma. You can have an increased risk of lymphoma, that is a B cell lymphoma. So I said B cell lymphoma, B cell lymphomas. And please, please, please be alert from this B cell lymphomas. Please do catch B cell lymphomas. Lymphadenopathy, if you have seen a patient of lymphadenopathy, patient is having lymphadenopathy, first rule out the lymphoma. Okay, because if the lymphadenopathy is persistent, asymmetric, painful parotid enlargement, this is associated with B cell lymphoma. If there is a cryoglobulinemia, investigate for B cell lymphoma. If the complements are less, like C3, C4 are less, B cell lymphoma. With a palpable purpura like picture or leukopenia, you must be investigating for B cell lymphoma, right? So these conditions are important, and with this we complete the most important part, that is our extra glandular manifestations of Sjogren syndrome, right? Extra glandular manifestations, and after this extra glandular manifestations, we'll go to the management of Sjogren syndrome. Okay, let's see. First, management. We'll look at the management. Look at the management. Okay. This thing which is done, the investigations which are done, look at this. The diagnosis, symptoms are dry as dry mouth, or you know, stigmatist, I told you, tear flow less than 5 mm, or for 5 minutes or 5 minutes onwards, you can say. Ocular staining, okay, another stain which is given in narrations, rose bengal, lissamine, and fluorescein. Okay, we have some salivary finding or salivary flow. If there is a unstimulated flow less than 0.1 ml per minute, unstimulated flow less than 0.1 ml per minute, this salivary flow, this is suggestive of Sjogren's. You can do salivary gland biopsy. If there is a salivary gland biopsy, I told you we have a focal lymphocytic sialadenitis. Okay, minor salivary glands, you have a focal lymphocytic sialadenitis. Okay, autoantibodies, you know, ANA, RF, anti-Ro, anti-La. Okay, basically this ANA, anti-nuclear antibody, is associated with this screening test. It is common for all connective tissue disorders. This anti-nuclear antibody, ANA, this is screening test for all CTDs, that is connective tissue disorder. It is a screening test for all CTDs. It is positive in about 65% of, in about 70 to 80%, or you can say 85% of people with Sjogren's. But ANA negative people are also there. If ANA negative is there, then you have to do the ANA profiling. Whenever you suspect a disorder, first thing ANA is done. Okay, anti-nuclear antibody. If this ANA is positive, then fine, Sjogren's. If ANA is negative, in 15% of patients with Sjogren's, ANA comes negative. If ANA is negative, then you have to do ANA profiling. ANA profiling, right? So ANA profiling has to be done, and you can write that it is positive in 85% of people with Sjogren present in 85% of people with Sjogren. Okay, and classification criteria is ACR or Euler criteria. Okay, objective test plus serology. Okay, this is done. And the pattern which is commonly seen in this Sjogren, the immunological pattern which is commonly seen in this Sjogren is basically what is called fine speckled pattern. Which pattern? Fine speckled pattern where the metaphase cells are negative, and this is suggestive of anti-Rho and anti-La. Okay, and here it is suggestive of fine speckled pattern is suggestive of Sjogren. Here only interface cells are stained, metaphase cells are not stained. Okay, and this is suggestive of Sjogren. Okay, this is done. But if you get a coarse pattern, okay, then it has other implications. If you get a dense fine pattern, then other implications. If you get a dense fine pattern in this condition, okay, then all the CTDs are ruled out. So we don't have connectivity. You can investigate for other disorders. But in rheumatology, anything is possible. Okay, so it's a multi-system. If you get, right, like that. So fine speckled pattern suggestive of Sjogren. This you have to keep in mind. Fine speckled suggestive of Sjogren. Okay, this is thing. And the investigation of choice is, salivary gland biopsy is there. Okay, this is a gold standard or investigation of choice, that is focal lymphocytic sialadenitis. The focal lymphocytic sialadenitis is pointing towards Sjogren syndrome. And we have something called sialography. Okay, this in diagnosis you can add. Sialography. Okay, sialography is the same thing. Salivary flow, unstimulated flow less than 0.1 ml per minute. Okay, this is a sialography. Less than some books write 0.15. Okay, 15 minutes. Okay, then you can do ultrasonography of salivary gland. Okay, you can do USG of salivary gland, and you will see there is a loss of the homogeneity of the gland. You will get a loss of homogeneity of a gland. The gland will look heterogeneous. Okay, so other thing, the sialography is done, and other thing is the USG of salivary gland. And then in USG of salivary gland, you will find loss of homogeneity of the gland. You will find loss of homogeneity of the gland. Okay, so this we come to the end of the management criteria. Okay, this is come to the end of the management criteria, and now we'll start with a other important thing, like the differential diagnosis. What are the differential diagnoses you get in Sjogren? Age related dryness. As you get old, the body secretions decrease according to age also. Okay, so we have to you can say differentiate from age related dryness and Sjogren related dryness, right? Drug induced sicca. We have something called drug induced sicca, some anticholinergic drugs. You know about anticholinergics, they decrease the secretions, right? Antidepressants too. Chronic infection, I told you, HCV, HIV and TB kind of relation. You should rule out sarcoidosis, amyloidosis. So sarcoidosis and amyloidosis are such notorious fellow that we don't have a particular understanding on the basis of that, right? You have to rule out the sarcoidosis and amyloidosis also. Head and neck irradiation. This head and neck irradiation can cause the cells to dry and decrease in secretions. So this head and neck irradiation, the GVST, you have to rule out GVST also, graft versus host reaction, right? The sarcoidosis is presenting with interstitial lung disease, with uveitis, with hilar adenopathy, right? This you have to rule out GVST, you have to rule out IgG4 related disorders also. IgG4 related disorders is primarily characterized by pattern of fibrosis. Okay, it is a story-form fibrosis, which is a pathological diagnosis, right? Plasmacytic infiltrate can present with pancreatitis, right? So IgG4 related disorder, you have to rule out this. Age related dryness, drug induced sicca, HCV, sarcoidosis, amyloidosis. Head and neck, graft versus host, and IgG4 related. The most common, you can say, you can remember this sarcoidosis, you can remember, and this IgG4 related disease, you can. You have to rule out this. You have to rule out. Can drug induce, you can remember. Okay, these are the differentials. These are the differentials for this condition. Okay. Now we move to the last part of our discussion. Okay, we have come a long way, and now here we are in the last part of our discussion. That is the management. How to manage this condition? Symptomatic treatment. So dry eyes. What can you do? Of course, you can do artificial tears. You can give artificial tear drops. Artificial tear drops is a compound which is called carboxymethyl cellulose. There's a compound called carboxymethyl cellulose. Okay. You can give lubricating ointments. Lubricating ointments. Punctal plugs. Okay, these are ophthalmological things. I'm not going to that. Dry mouth. Dry mouth, what can you do? Frequent hydration, of course. Frequent water. Sugar-free gum. This sugar-free gum is basically causing a release of saliva. You must have observed that whenever you eat chewing gum, then saliva production increases, right? Sugar-free gum. Saliva substitutes. Okay, saliva substitutes. Saliva substitutes are very common. Pilocarpine or cevimeline. Cevimeline is a very good drug here. Cevimeline. Cevimeline is muscarinic agonist. It will increase the secretions. It will increase the secretions. And dental hygiene. Just a minute. Okay, dental hygiene. That is prevention of dental caries. Dental caries are common here, right? Antifungals for candidiasis. If you have a oral thrush, in case of oral thrush. Oral thrush treatment. Okay. And vaginal lubricants for dyspareunia. Okay. Because they were a dry vagina. Okay. So this is the symptomatic treatment. This is the symptomatic treatment basically of glandular Sjogren's. Okay. The glandular manifestations are taken care of. We have some extra glandular Sjogren's like life-threatening, you can say, manifestations, systemic therapy. We have arthralgia. What you can give for arthralgia? NSAIDs for arthralgia. You can give NSAIDs for arthralgia. You can give hydroxychloroquine for fatigue and skin involvement. Okay, hydroxychloroquine can be given. You can use corticosteroids and immunosuppressants. You can give corticosteroids and immunosuppressants. You have fatigue and arthralgia, then you can give low dose steroids. Okay, low dose steroids. You can use low dose steroids, and low dose steroids I mean less than 7.5 milligram per day. Less than 7.5 milligram per day. These are low dose steroids. Plus, you can add here NSAIDs for arthralgia. Plus hydroxychloroquine for fatigue and arthralgia combined, and skin involvement to hydroxychloroquine. So low dose steroids, NSAIDs plus hydroxychloroquine is what is given for the systemic treatment for this extra glandular. Whenever you suspect extra glandular Sjogren's, this is a treatment for extra glandular. Extraglandular Sjogren's. If the person has severe infections, if the person has severe life-threatening infections, okay, or severe life-threatening Sjogren, life-threatening, life-threatening, then you will give this, you will increase the dose of steroids. The steroids, whenever you are giving 7.5, right, you can increase the dose. You can increase the dose to You can increase the dose. You can just doses are not important. High dose steroids, high dose steroids, and do add the immunosuppressive agents as well with this. You can use immunosuppressive agents, immunosuppressive agents, right? MMF. What is MMF? Mycophenolate mofetil. Okay, you can use mycophenolate mofetil in this condition. Life-threatening high dose steroids plus immunosuppressive agents. Okay, and if it is a refractory condition, if it is a refractory Sjogren's, then you can also add rituximab. Okay, rituximab, and this rituximab is anti CD20. Anti CD20. You can use rituximab in this condition. Okay, so let's read. Methotrexate can be given. Azathioprine. Methotrexate has many side effects, so not that preferred. Mycophenolate is a wonderful drug. Mycophenolate for severe systemic disorders, and rituximab, that is anti-CD20 for refractory systemic disease or lymphoma risk. I told you lymphoma risk also, and in severe refractory disorders you can use rituximab. Okay, this is done. Yes. So we have come to the end of the Sjogren's. It was a nice discussion. It was a nice disease per se. And this disease, you can say, is one of the diseases where you cannot localize the symptoms to one side. The salivary gland is involved in only 50% of cases. In 50% is extraglandular one, right? Extraglandular one, people are presenting with arthralgia, fatigue, lack of symptoms. Then CNS, lungs, kidneys, in which organ it is not manifesting, right? In skin also, we saw there is a palpable purpura. Palpable purpura, the diagnosis changes to that B cell lymphoma type thing. Okay, that thing. Hematological cytopenias, they're present with cytopenias, they're presenting with lymphomas, right? And in musculoskeletal arthralgia, myalgia, Raynaud's phenomena, okay, and nervous system cognitive dysfunction, ganglionopathies, okay, what not, you can say. SL is one of the type of disorder. Sjogren is another type of disorder where you can't just think. And Sika symptoms are there. Sika symptoms are classical of Sjogren's. This dry eyes, dry mouth, all of this are classical of Sjogren's. This diagnosis you have to remember all of this. On the gold standard one, okay, this salivary gland biopsy, I haven't mentioned it. It is the gold standard or investigation of choice. IOC or gold standard. More than one focus per square of tissue. We take more 2 by 2 and analyze it. That is 4 square of tissues. If you get more than one focus of focal lymphocytic sialadenitis, more than one focus, then it is diagnostic of this Sjogren syndrome, right? So with this, we come to the end of Sjogren syndrome. Let's meet in any other chapter of this rheumatology or any thing which I would like to discuss with you. That's for today. That's for today, and I hope you understood this one pitch. The whole Sjogren is complete. Most importantly, the whole Harrison's is complete, right? The Sjogren part of Harrison's is complete. I have left one thing that is not much, you can say, of diagnostic significance. Just one thing, that is the classification. The classification criteria, the scoring of Sjogren. Okay, the scoring of Sjogren. If you want, let me discuss with you. Okay, it will be complete. So let me discuss with you the scoring of Sjogren. Okay, if the histopathology is showing focal lymphocytic sialadenitis with a focus more than one with 4 square focus. Okay, the first thing we analyze is the focal lymphocytic sialadenitis. Focal lymphocytic sialadenitis more than one focus in 4 square of tissues. Okay, if this is same, then you give the score 3. It is a good one. This score, this is a score, and this is the criteria. This is the criteria. Focal lymphocytic Scalenitis. Okay. If there is a presence of anti-Rho or SSA, anti-Rola present, again you give the score 3. Okay. Anti-Rola 3. If you are getting a Sika ocular staining more than 5 using the stain, right? Staining, ocular stain score more than equal to 5 using which stains you use? Histamine or fluorescein. Rose Bengal is also used. Okay. If you are getting the score, then give 1. Give score 1. Okay. Or we can use a other stain is that is the Venn Gingerville stain scoring system. That's not important. Rose Bengal score of more than 4 is also there, or Rose Bengal more than equal to 4. Rose Bengal more than equal to 4. This is also there. This score 1. Then the fourth thing is that if you are getting skimmer test, if getting skimmer test less than equal to 5 mm in 5 minutes, in at least one eye also, less than equal to 5 mm in 5 minutes or beyond 5 minutes, again give the score 1. Okay, 3, 3, 1, 1, 1. Okay, 5 criteria are there. And the last criteria is that unstimulated whole salivary flow less than 0.1. I told you, right? Less than 0.1 ml per minute. Less than 0.1 ml per minute, you give the score 1 again. Again 1. Okay, this thing is there. So this criteria, so we have the scores 3, 3, 1, 1, 1. 3, 3, 1, 1, 1. Okay, so whenever you have a primary Sjogren's, how to you can say diagnose primary Sjogren's according to this score. So primary Sjogren, at least one symptom of dryness must be there. Okay, at least one symptom of dryness must be present. That is Zika symptoms. Any dry mouth, anything, any oral or ocular dryness. Plus, if the total score is more than equal to 4, total score is more than equal to 4. So at least one symptom, at least one Zika symptom, you write. Ocular, it may be ocular, maybe oral, plus more than equal to 4 score. Just a minute. More than equal to 4 score. Okay, then it is diagnosed of a primary Sjogren's. Diagnosed of a primary Sjogren's. Okay, so this is not that important for you, but this is what is the criteria part. This whole part is basically the criteria. Okay, this is the 2016 criteria, American College of Rheumatology criteria, or European League criteria. You can say European League Against Rheumatology criteria for Sjogren's. Okay, so 2016 American College of Rheumatology criteria. I told you, right? ACR score or Euler score. Look at this. There was a written. Yes, ACR score or Euler score, I told you, right? So this is American College of Rheumatology and European Union League Against Rheumatology. Rheumatism, not rheumatology, rheumatism. Okay. So European Union League Against Rheumatism and American College of Rheumatology criteria, which is taking in account subjective test plus taking in account serology, that is the anti-Rho and SSA. This I mistakenly wrote anti-Rho. This is anti-Rho, okay? Anti-Rho, not La. Anti-Rho. That is SSA. SSA positive. Okay, not SSP. So with that, we completed Sjogren's syndrome in total. I hope you enjoyed the discussion. The rheumatology discussions are very, very fascinating. We'll meet in other disease. Okay. So it's perfectly 59 minutes and 1 hour. 1 hour as Sjogren's is more than sufficient for any entrance exam or for any practical or for any case if you want to deal in your future. I told you about management, I told you about diagnosis and everything. So that's all. Bye bye and take care.